Hi friends, she is a 68 years female presented with complicated cataract. We have planned phaco with single piece hydrophobic lens. Here we will see the steps of the phaco and few things to be taken care in these complicated cases. First of all, you should take clearance from the VR specialist for any posterior segment pathology. Here I am showing the 3 planar posterior limbal incision. First plane followed by second plane. You can see my keratome has a mark which shows the 2 mm length. We are going straight. Then third plane is parallel to the iris. It gives a water seal 3 planar incision to us. Now it's time to stain the anterior capsule. In these cases, the staining is very important as you don't know the capsular health, zonular health. You may need to do a CTR insertion. So the capsule should be stained properly. The air is expressed out with the help of the visco. Now with the help of the iris repositor, we are breaking the posterior synechiae. I am lucky that this case is having a good dilatation. Now it's time to check the capsular health. Once we will touch it with our capsulotome, we will come to know. Luckily, it seems to be okay. We have planned at least a 5 mm raxis in this case. In these cases, a bigger raxis can lead to decentration of the lens, and a smaller raxis, there are chances of phimosis of the bag. So, adequate capsular raxis is must. You should plan for 5 mm. The raxis is finished. Now it's time to do the side port incision 3 clock hours away from the main wound. Here you have to use good amount of visco also to avoid any endothelium damage, as these cases there are high chances of endothelial compromise. Hydrodissection is done. Good hydrodissection is very important because there are chances of corticocapsular adhesions. You should get a good nuclear rotation in these cases. Visco is injected. Now with the help of the dialer, we will rotate the nucleus. It makes the further phaco steps easy. Entering into the eye, pushing visco, HPMC 2%. Here I have zoomed. You can see under phaco 1, we are entering into the eye, eating up the epinucleus to expose the endonucleus. Making a trench in the soft cataract, we have to make a long and deep trench. Avoid making any wide trench, otherwise it will be difficult to break this soft nucleus. The trench depth should be at least 80 to 90% of the nuclear thickness. Getting the crack. We have got 2D segments. Now rotating the nucleus and shifted to phaco 2. Here we have to take care that your phaco should be low flow, low pressure phaco. Emulsifying the nuclear pieces. Should be careful that there should be no rent in these cases, as already this patient has heel choroiditis. If any rent is there, it may increase the posterior segment pathology. So we should be careful. In one go, we should complete the case. Now it's time to push visco and do the cortical wash. I am using my coaxial IA. The vacuum is 450. Pulling the cortex towards the center and then aspirating. You should not apply the full vacuum at the periphery, a small amount just to hold the cortex, pull it towards the center, and then press the foot pedal to apply the full vacuum. In these cases, the concern should be taken from the patient preoperatively that the vision outcome will be depending on the condition of the posterior segment pathology. So it is very important. You should be ready with CTR, iris hooks, anterior vitrectomy. Luckily in this case, everything went well. The pupil got dilated after relieving the posterior synechiae. Now it's time to push the visco, and here I have planned Care Group magnificent lens. It is an advanced monofocal lens. I always load the lens in the microscope. Inverted S shape. After putting it into the injector, always check the movement. Now it's time to push the lens into the bag. With the dialer, I use the counter force. As you can see, as I am pushing the cartridge, it's not going inside, so I have to increase the tunnel length. You should not put so much pressure that there can be a DMD or distortion of the wound. It's better to increase it little. It's 2.8 mm incision, but the cartridge was not going properly. Now you can see it's easy to push the lens in the bag. An important thing, you can see there are two holes in this lens. This magnificent lens just optic comes like the Palma lenses previously we had. So sometimes you get confused if someone had this magnificent lens into the eye. It just looks like they have a Palma implanted unless you see the sticker on the discharge notes or you see the haptic of the lens. Visco wash behind the IOL, very important to avoid any intraocular pressure rise. Post-op, a good AC wash is must, should give it some time. The angles should be washed properly. Now it's time to hydrate the wound. We'll do some AC lavage with the BSS. It will clear any hidden cortical particles. Hydrating the main wound, and the case is finished. Thanks for watching.